We're going to talk about benign skin tumors, and this should be of interest, if nothing else, out of self-preservation, because we all grow these. And aside from your patients, you might like to know what to do with them yourself. And I have no conflict of interest. Why do we bother talking about these things? Well, because we are worried about it being cancer, and they, the patients, are worried about it being cancer. And sometimes they're symptomatic. Sometimes they may lead to some disruption of function. They're cosmetically distressing. And every once in a great while, and I will try and point those out, there are signs of significant internal disorders. Usually they're part of a syndrome. And if you see this, you should think about that sort of thing. Not very common, because these all by themselves are ubiquitous, but every once in a while you have to think about that. So size doesn't dictate benign or malignant. These are all benign, but they're pretty striking, right? And you can have a little teeny tiny thing that's a melanoma that can kill you. It's 2 millimeters in size. So size alone doesn't determine. It's morphology, histology, and you get clues often not only from morphology, looking at it, but geography, where it's located, often dictates which benign tumors you might be concerned about. So there are a multitude of these things. They may be characteristic, but they can look like malignancy. They can simulate it clinically. They can also look like inflammatory disorders. Biopsies are encouraged. How many of you routinely do skin biopsies yourself? That's good. That's at least half plus of the room. If you don't, it's really easy. I would encourage you to learn, all of you to learn how to do that. Why do I say that? Because in the first place, there aren't enough dermatologists to deliver dermatologic care in the United States. We deliver, based on brand new 2016 statistics, about 35% of dermatologic care. That means 65% is delivered by everybody else, mostly primary care, and I include in that pediatricians as well, primary care for children. So part of distinguishing diagnoses is skin biopsies. Very easy to do. They don't need to be gigantic. And even if you don't like to suture, you can usually, when it's a 3 millimeter hole, you can usually stop the bleeding in a pretty easy way. But if you're not sure, biopsy, if you don't do the biopsies yourself, send them to someone who does. Always remember, if you're removing a benign lesion, anytime you remove anything, there's a risk of leaving a scar. There's a risk of leaving some pigmentary abnormality, hyper or hypopigmentation, because in the process you might stimulate the pigment cells to make more, you might destroy them. So you always have to weigh the risk versus the benefit. What I say is, are they going to look better when I'm done, or is there a significant risk that they're going to look worse? So always keep that in mind, and never, never, never discard anything. I used to do, I don't now because it's frankly a little too stressful at my advanced stage, but I used to do a lot of medical legal work. And you know, most of the time what I saw in defending physicians was not so much that they did something wrong as it was a failure of communication. The doctor didn't answer phone calls, whatever. But the one thing, other than missing diagnosis of melanoma, the one thing that I saw over the years in a number of cases, somebody ended up with a bad thing, and the physician, usually primary care, had removed something and said, oh, I know this is benign, I'm not going to send it off to the path lab. Now, we'll never know because it was discarded. But the plaintiff's attorney made a big deal about that. Probably was the melanoma that killed Mr. Jones, and now his estate is suing that physician. Never, ever, ever discard tissue. Even if you're mostly sure, 100% sure in your mind that something's benign, if you take it off, send it off to the pathologist. And I will tell you, despite 40 plus years of doing dermatology, I'm not always right. So what you think you see may not be in reality what it is. Never, never, never discard tissue if you take it off. Okay, let's talk about some benign growths. Seborrheic Keratoses. Rough, pigmented. You can take a fingernail and stick your fingernail under the edge of it. There's a little gap between the lesion and the underlying superficial skin. Seborrheic Keratoses. These are very common. They're seen primarily in older individuals, both genders, all ethnicities. They look like they're stuck on. The roughness is almost uniform. There's a large differential, which of course includes melanoma, and there's some variants we're going to talk about. These are all seborrheic keratoses, however. Look at the variation in size, in shape, in color. So they come in all sorts of flavors. Look at that gigantic black one. Boy, if that didn't scare the living daylights out of you, it should, but it's nothing more than a very large seborrheic keratosis. Do you know, on the eve of the Normandy invasion, Dwight Eisenhower, General Eisenhower, was found to have a big one of these on his back, and they cut it off with huge margins. Hopefully they thought it was a melanoma. Hopefully he would survive to finish leading the Normandy invasion. It's sitting in the Armed Forces Institute of Pathology now. This gigantic piece of tissue, and it was just a seborrheic keratosis. Kind of looked like that one that's on the upper left there. Macular seborrheic keratoses are flat. So most of these have some elevation. These are flat. They may vary a little bit in their color. They're usually a little scaly, a little rough. If you look at them with light coming in from the side, they look like a matte photograph. So they're not shiny, they're dull compared to the surrounding skin. And that's a little pearl to differentiate them. Stucco keratoses sounds like they're stuck on. That's what they are. Multiple of them, small, white, rough things. They're hereditary. They're usually found on the feet. And these beautiful examples are actually from my foot. My dad had them, my grandfather had them, and I have them. And my son will have them too at some point in life. They appear later in life. You don't have them when you're a child, teenager. These all come on later in life, usually after 40. Now, if you want to take these off, or patients ask to have them off, they all hate them. So this is all going to change. I'm going to tell you now, but I'm going to give you a little clue. So if you don't really think it's a melanoma, you're really pretty sure that's what it is, you can freeze them off with liquid nitrogen. How much freezing is enough? Nobody knows. There's no standard. What I say is you freeze them until they look rock hard. Let it thaw, and then give them a short burst afterwards. I do a double freeze. Rock hard, and then done. And you should try and freeze just a little bit around them. They may get edematous. They may hurt for about 20 to 30 minutes. Then they get necrotic and fall off. Another way to take these off is to electrodesiccate them. Basically, you just cook them. There's something aesthetically beautiful about the smell of burning flesh first thing in the morning. For me, but maybe not for everybody. And you've got to kind of warn the patient it's going to be a barbecue and you're the barbecuee. But if you cook them and then you just take a gauze pad and wipe them off, you already have hemostasis and they're gone. You don't have to wait for them to fall off. And then the other thing you can do is shave them off, either with a blue blade, a little instrument that's called a derma blade that forms a U when you squeeze the two ends of it. I'll show that to you in just a second. Or with just a scalpel blade. You shave them off and then you obtain hemostasis, which could be pressure, it could be a little dry sol, it could be a very light electrodesiccation. If you're not sure what they are, and seborrheic keratoses can look an awful lot like melanoma, I'll show you just a second some examples, then you really need to take it off in a way that you have a specimen, so you wouldn't freeze, you wouldn't electrodesiccate, you'd shave or excise, or a very deep scoopy shave so that you get the base of it. Remember, seborrheic keratosis on the legs and face can scar fairly substantially. Now, if you walked into the room, these are real patients that I walked into the room, and they were sitting there sweating, worried that they had melanoma, and you saw those dark lesions, solitary dark lesions, Your first impression should be nodular melanoma. This patient's in trouble. Those are two different patients. You can see the lesions in slightly different locations. And then up close, they're rough. They're seborrheic keratoses. But from a distance, they look really, really bad often. Or look at this one. When you walk in the door and you see that gigantic pigmented lesion from the length of the door to the examining table, that should make you worried. But when you get up close, this is a beautiful close-up to show the rough, sort of polyangulated portions of the lesion, totally benign. You're not sure? Take a little bit as a biopsy. You're not sure. Biopsy is an easy thing to do, and it gives you the definitive diagnosis, and then you can take it off. If you're sure, this one I was sure. He didn't like it, so I cooked it. I needed that smell first thing in the morning. It was good. Or you can shave it off like this. There's a scalpel. You leave a superficial ulcer that's bleeding, so you have to do something to get hemostasis, which can be very light electrocautery, or something else like Drysol, or just pressure, and then a pressure Band-Aid so it doesn't start bleeding later in the day. I want to remind you, if you use electrocautery, that's a very efficient way of destroying pigment cells. So in this person who's fairly light complected, it doesn't matter too much. It might leave a slightly lighter than the surrounding skin area when it's all said and done. But if this were a skin of color, if this were African American or Hispanic or Mediterranean, Oriental, Asian, then you might be a little concerned about using electrocautery to obtain hemostasis because you might end up with a bone white spot. And that's almost worse than the thing you started with. If you wanted to scoopy shade, this is the derma blade, so there's a little plastic thing you squeeze, and then you make a U shape of a blade, and you can scoop the thing out, and that gives you better depth. Of course, you are going to leave a hole where you have to obtain hemostasis. In this case, hemostasis was putting on some Drysol that's usually used to treat hyperhidrosis, but it coagulates protein, so it just seals off all the blood vessels. Okay. This is often talked about and rarely seen. It's called the sign of Lesser Talaat. There's two French folks who describe this. And what this means is the patient says, and usually they're backed up by a spouse or significant other, that they didn't have a single seborrheic keratosis. And over the course of a few days to a week, they had the explosive onset of multiple seborrheic keratosis, usually on the trunk, chest or back, mostly on the back. And this is a sign of occult internal cancer that may be totally asymptomatic. This person ended up having colonic adenocarcinoma that he didn't even know. He had no symptoms, no bowel symptoms, no blood, no weight loss, no nothing. No family history. So it's very, very, very rare. First 4 years of my career, I worked in MD Anderson Cancer Hospital, and I saw one case. And in the next 36, 37 years, I've seen one case. I've only seen two. So chances are you won't see this. But take it seriously. If someone says, I never had one of these things, not just, oh, I'm getting more and more and it's bothering me, because that's fate. That's destiny. If you want to change that, you have to change your parents. It's a little too late. But if they say, I didn't have a single one and now my back is covered with them, think about internal cancer and do an appropriate workup. It's not always colon. It's appropriate workup for gender and age. So you think about lung, you think about colon, you think about breast, you think about prostate in a man, et cetera, et cetera. Sign of Lesser Talaat. Dermatosis papulosa nigra, loosely translated, that's dark spots of the skin. They're rough. They may be teeny tiny, they may be medium sized, or they may be very large. These are seborrheic keratoses that are familial, seen in American black individuals, African Americans. So it's seen in 30 to 70%. There's one of the most famous people in the world who has them all over his face. They're internally consistent, so the family all gets, most of the time, small ones, or they all get medium-sized ones, or they all get big-sized ones. And these can be removed either by lightly freezing them or lightly electrodesiccating them, or you can snip them off sometimes, but most of the time they're pretty close to the skin, so snipping is difficult, or you'd snip normal skin off. But keep in mind, this is skin of color, and if you freeze, and especially if you desiccate with electricity, you may leave dyschromia. So what I usually do in patients who want these off is I try one or two, I take a picture, I mark which ones I'm treating, because I can't remember weeks later. So I take one or two on one side of the face off to the side, and I freeze them, and I take one or two on the other side of the face, and I cook them. Then I have them come back in about 3 to 4 weeks. I see which looks better, and that's how I treat the rest of them. Because you never know. There's no way of predicting. Okay, sebaceous hyperplasia. These are very, very common, usually in multiplicity. They're small, 2 to about 4 millimeters. They're yellowish in color. They have a central depressed area that's sometimes called a dell or an umbilication, like the umbilicus. And they often have small blood vessels coursing over the center. So you have a papule, you have a bump that has a little dip in the center with blood vessels on the surface. So individual lesions may look very much like a small basal cell carcinoma. And sometimes it is truly impossible to distinguish between those two entities, in which case you should biopsy or just remove the whole thing. If you're sure, you can destroy them. If they have 5 million of them, they tend to occur particularly on the forehead, but these are usually on the face. You don't see many of these on the extremities, the trunk, almost never. I can't think of a single one I've ever seen on the legs, so we don't have very many sebaceous glands there, if at all. So you can electrodesiccate them. Some lasers will work on them. If someone is just covered with them, if you can get their insurance to pay, or they pay out of pocket, which is difficult, oral isotretinoin will stop them, but it's really difficult now because there's a whole program to prevent pregnancy, and it's complicated to get the drug off label. They're increasing in incidence as we get older, over 40. And almost everybody who gets these will say, I have or had, when I was younger, very oily skin. And here they are. These are very, very good examples. Now, I will tell you, photographing these is not easy. So I enhanced the color. I didn't change it. I just upped the intensity of the color so you could see them. They're yellowish to orange-ish with that little central dell. And there's some very close ups. You can see some blood vessels on a couple of these. Sebaceous hyperplasia. Do they mean anything? Like seborrheic keratoses, dime a dozen, but if you didn't have them, you have a gazillion of them, think internal cancer. Well, really, most of the time, no, but they can be a small component of some syndromal cancer disorders. I've listed them there. I would not, based on having sebaceous hyperplasia, work anyone up for cancer. But if they happen to have cancer already, and or they have some of the other components of the syndrome, you might think about that. And there are genetic tests for all of these now. It's really uncommon in my experience that sebaceous hyperplasia lead to another diagnosis. And I told you how often I've seen that lesser Talaat with Seb Kers. So there is an association, but it's a very weak one. Nevis sebaceous hyperplasia, Nevis sebaceous, anything that has the word sebaceous in it, generally speaking, is going to be yellow to yellow-orange in color. These are fairly striking. I didn't have to enhance the color on these at all. They're yellow to yellow-orange, and unlike a lot of other benign tumors, which appear later in life, these are present at birth. They get somewhat bigger. The thing that they get most strikingly as the patient ages is thicker and rougher. They occur on the scalp and on the skin of the face that abuts the scalp. So the forehead, along the temple, any of the skin that's right at the hairline. They're present at birth, as I said. The catch about them is, one, if they're in a hairy area, there's usually no hair there. They have displaced the hair follicles. So for cosmetic reasons, if it's up close front, they might want to have them off so that you can put the skin back together and they have a normal hair. But the other thing is they grow other tumors within them, starting at adolescence and into adulthood. So they're present at birth, but by the time an adult has them, they may have run the risk of growing something else in them, which is more deadly than the benign part of the lesion. Basal cell carcinoma is the most common thing that grows in them, but also sebaceous carcinoma, which has a high metastatic rate. So the message here is, if this has been present, if you're seeing adults, and this has been present their whole life, and all of a sudden they say, in the middle of my orange thing, I've got this black bump or some other bump that wasn't there before, you need to really take that seriously. Best thing to do is take them off to start with, but it's in children, neonates and infants and toddlers, and no one really wants to do surgery on them, but it can be done, even if big lesions can be taken off in stages, so it's not so traumatic to take a huge excavation. That's really the best thing to do. And it's best to remove them before puberty because we think hormonal influences are responsible for their enlargement, their thickening, and ultimately they're growing other things within them. So there's examples in the newborn. You see that color? It's kind of a yellowish orange color. You see when it's in the scalp, there's no hair. Now compare these to lesions that the parents said, no, it's okay, just let them go. And now you have an adolescent and an adult with these, and they're much thicker, they're much more nodular, still hair loss. They're asymptomatic, but they are cosmetically distressing, and then they can grow stuff in them. Here's an example of an individual who grew something in it. So you see the fairly uniform, dull orange color. It's much thicker than it was at birth, which he said was the case. He's 52 years old. But look, he said, but now there's this black thing in it that wasn't there before. Luckily, that was just a highly pigmented basal cell carcinoma. But now that he's grown one, dealing with that small basal cell was no problem. But then do you leave the rest of the lesion? He's already demonstrated the propensity to grow something else in it. What if he grows a sebaceous carcinoma in it, which could kill him? So at that point, we really recommended the whole thing needs to come off, which he was, of course, happy to do at that point. But they grow things in them. That's the key. Trico Epithelioma. These are flesh-colored, kind of translucent. Any individual lesion might suggest basal cell carcinoma, but these almost never, I won't say never because they do happen as individual lesions, but most of the time you're going to see lots of them. They're going to come in groups, and they'll be in the center face, which is a place where basal cell carcinoma occurs. Again, you're not sure. You can biopsy or remove the lesion, send it off for histologic examination. But most of the time these come in big groups in the center of the face. They also appear in childhood and young adulthood. So this is another example of not later in life. There aren't a whole lot of these for the benign ones. Women more commonly than men, but men can certainly get them. And there is a syndromal variant. It's an autosomal dominant. So half of everybody in the family in each generation is going to get them. They can be electrodesiccated, they can be shaved. They really actually respond best to a variety of laser interventions. So if you don't do those, send them to a plastic surgeon or dermatologist that does the appropriate laser intervention for this. And they're very striking, very flesh colors, so they match the surrounding skin. It's just a bunch of these bumps all together, usually central face, around the nose, not around the eyes. That's a different lesion. Geography matters, but around the nose primarily. And in skin of color, they're going to be skin colored, so they're going to be pigmented similarly to the skin of the patient. So these are all trichoepitheliomas, totally benign, cosmetically distressing. Okay, what are these? Sebaceous cysts or epidermal cysts. So basically, this is a cell wall, which is normal skin, that still has sebaceous glands in it, secreting sebaceous material. That's the cheesy stuff that's in it. And then it grows, and sometimes they're small, and sometimes they're very striking. I picked very striking ones for a purpose of illustration, but these can be very small. Most of the time, they're asymptomatic. About 2.5% of the time, they become inflamed. We often say infected, but most of the time, they're really not infected. They're actually just inflamed. But they can occur anywhere. They have a high propensity of face, neck, and trunk, particularly the back. But they're benign, not painful unless they're inflamed. When do they come off? If they're cosmetically distressing or if they've already had a bout of inflammation. You don't take them out while they're inflamed because it doesn't heal very well. But when it's resolved, wait a couple months, and then once they've been inflamed, they're going to be inflamed again. You can take it to the bank most of the time. So rather than having this repeated cycle of, oh, it got big, it hurts, it's red now, then you take them out. They should be removed. Now, taking them out. You can make a big production of it, or you can make a little production out of it. I like little productions if I can get away with it. If they have a central punctum, sometimes they'll have that little hole in the center, as this one does. That's your point of entry. If they don't have the little punctum, just roughly the center of it. And you can use a small punch, like here I've circled it. I'm putting a punch in it like I'm doing a punch biopsy, and I'm going to take a central core out. That's left a hole. You can see the cheesy material in them. Then you get the aesthetically pleasing job of squeezing them. And out comes all this cheesy material. Isn't that cool? But there's still a wall left underneath. And if you leave the wall, these will reconstitute themselves. So you reach in your hole that you just made, you got the sebaceous material out, and usually with a forceps or a pickup, you can just get these walls, you hold on to the wall, you pull it out, you cut it off, you're done, you sew them up, and that's it. And they heal quite nicely. Gigantic ones are a little more difficult to do that way, but your average epidermal or sebaceous cyst is pretty easy to do that way. Cosmetic outcome is fine, and there's no big problem. Gigantic ones, you may have to actually excise, but most of the time the punch removal is sufficient. There's another example. In this case, there was no central punctum, so I made a little circle, drew a line in the center of the line that went from the longest across the longest dimension, and right in the center is where in this case, it was a little incision rather than a punch. You can do either thing. Okay, when they're inflamed, usually they're really not infected. When they're inflamed, you open them up. I still like packing them. That's kind of old school, but there's no study that says that isn't what you should do. And then advance the packing a little bit every day. What comes out should be cultured. Most of the time, when this material comes out, and there's usually admixed with a little bit of pus, that's enough. You don't really need antibiotics. If there's a lot of red around it, say an inch, inch and a half, 2 inches around the cyst is all red, then it's worth using an antibiotic. Now, this is a whole different lecture on skin infections, but in point of fact, most of the time now in the United States, particularly in the southern states, this is an SMA function, in the southern states, this is going to be MRSA, methicillin-resistant Staph aureus, and the drug of choice, unless they're allergic to, it's doxycycline. Doxycycline, nationwide, there's about 12% resistance of MRSA to doxycycline, which used to be 100% susceptible. So you have to know your own local antibiogram and what works for what bugs. But the other nice thing about doxycycline, and I would say the same thing about tetracycline and minocycline, is that they're anti-inflammatory, doxycycline being the strongest. So it's not only anti-infective, it's anti-inflammatory. So you got this big red ring. That could be infection, that could be inflammation, but it doesn't matter which. If you use doxycycline, chances are pretty good. You're going to take care of the most likely organisms that are in there, and you're anti-inflammatory as well. But routine use of antibiotics on inflamed, maybe infected cysts, opening them up and getting the contents out is really the mainstay of therapy. Antibiotics are kind of optional. Okay, there's one thing these are associated with that's called Gardner syndrome. So this is multiple of these EICs, epidermal inclusion cysts. All the names are synonymous. But they also have lesions in the jaw, and sometimes those become symptomatic. So they'll have lesions they've had examined by somebody, the dentist, oral surgeon, and they'll have fibromas and lipomas, and we'll talk about Leiomyomas in a second. Their problem is they have premalignant colorectal polyps. Okay, these are very common. Milia, these are baby cysts. They're epidermal cysts, but they're really teeny tiny cysts, and people go bonkers over them. They go wild. Oh my God, take this thing off. That's your biggest problem in life. Hallelujah for you. So taking them off is really easy. I'm going to show you one here. I use these blood lancets, or you can use a little lancet that people use in their machines to check their blood sugar. Just a little lancet. You don't need anything fancy. A number 11 blade, scalpel blade, will also work quite well. And all you do is you make a little teeny tiny incision straight across them. And then I use, this is a Comedone Extractor. This is used to take blackheads out of the face of individuals with acne. I almost never do that. Our drugs, the retinoids and benzoyl peroxide containing agents, are so good at getting rid of blackheads. I don't sit there pushing out blackheads all day. I don't think my mom would be too proud of me if that's what I did for a living. But you can still get these. And so you make that little incision and you just put a little pressure on with the Comedone Extractor, which puts pressure all the way around. And what happens? Out they pop. That's it. No suture, a little Band-Aid. These are healed. And people are incredibly happy over this little 2-millimeter white thing that's not there anymore. You can make lots of friends. Maybe you'll get a nice present at Christmas if you take these out. Pilar cysts are not epidermal inclusion cysts. They're histologically much different. They have different components. They arise from the hair follicle. But for all intents and purposes, they're just like sebaceous or epidermal inclusion cysts. They're a cyst, except they're in the scalp. And so you can do the same thing, straight line or a punch, push, out it comes, sew it up, and you're done. They're exactly the same, except they aren't histologically, but they never do anything bad. They're asymptomatic. They sit in the hair. Okay, other things, skin tags. Oh my God, everybody in the world gets a skin tag now and again, and some people get lots of them. Where do they occur? The neck, the axilla, and the groin. Primarily those three areas. Sometimes around the eyes, especially on the upper lid, but really it's neck, axilla, and groin. They may twist on themselves. These are fibrovascular, so they're fibrous tissue with a little blood supply, and if they twist on themselves, they choke their own blood supply. They get a little painful, they turn black, and they fall off, and I say it's like losing a tooth. You know, you get the tooth fairy, get the skin tag fairy, and tell them, hallelujah, it fell off, you're fine. Or if they're in the process of falling off, if you feel really benign, you can snip them off, but otherwise they're going to complete their own self-destruction. They can be removed easily. They're small for the most part. There are some big ones, but most of the time they're pretty small, and hemostasis is very easy, just a tiny zap of electricity, electrocautery, a little dry salt, a little pressure, and they stop bleeding. So that's not the really big thing. What you do is you adapt the technique to where they are and how big they are. So there's a typical little skin tag sitting there. There's lots of little skin tags on the neck. They can be pigmented. Now I will tell you, let's say you listen to Uncle Teddy and you send everything off you take off. So you take off a bunch of skin tags, you throw them all in one bottle, pathologist is going to section all of them, and then skin tags times 14, one malignant melanoma. Whoops. Which one was the melanoma? And that's come up a lot nationally, US. It's one of the causes for legal action. So if you take them off, you really need to put them in separate bottles, because if one of them ends up being a problem, you need to know which one was the problem. If you took all these off and one of them came back as melanoma, what would you do? Take off the whole neck if you didn't know which one was? So you really need to individually, 2 inches above the clavicle, 2.4 inches above the clavicle to the left. I mean, somehow you have to designate which is which. What I like to do is I like to write with a erasable marker, A, B, C, D, E, take a picture, put them in bottles. A, B, C, D, E, I have a picture, I know which one was which. I know it's a lot of work for something that's totally benign, but God forbid you don't do that and you get in trouble, and I've tried to save people from that. It's not standard of care to put them all in one bottle. Just telling you right now. This is called a fibroma mole. It's a fancy name for big skin tag. These like to occur in the groin, upper inner thigh. This you're going to have to use anesthesia, local anesthesia, not put them to sleep. You have to use local anesthesia, and you have to do some surgical sort of intervention to get rid of them. Now, skin tags can be frozen off, they can be snipped off, they can be fried if they're tiny, or you can actually use a derma blade or scalpel to cut them off. It depends how many there are and what they look like and how big or small they are. So here's an example of freezing them. This is a special tweezers that's designed to be dunked in liquid nitrogen. They're cold. You grab the skin tag with them until the skin tag turns white, and you've now frozen the living daylights out of them. You've knocked out their vascular supply. They're going to turn black and drop off. Or you can scissors them off. You see how easy, because these are on a stalk, how easy it is to just snip them off. Or you can burn them if they're teeny tiny, just a little zap, little electrocoagulation, zzz, 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 done with a very fine needle. So you can do that. And if they're bigger, you might have to use a scalpel blade, hold them, pull them up, use a scalpel blade to cut them off. And this is a whole neck full of them being removed. You don't want to do this the night of somebody's anniversary or the day they're going to go see their kid graduate from high school or college, because they're going to be a little tender. They're not going to take long to heal, but do be careful about doing even these small procedures at a time when the patient wants to be comfortable. And also it looks pretty ratty for a day or two. Then the little crusts fall off, all the redness goes away, any swelling disappears. But just make sure they don't have any big social obligations the day or night that you're doing these. Now, do they have any significance? Well, it's just like sebaceous hyperplasia and seborrheic keratoses. They're a dime a dozen. There's so many of them that the likelihood of their being associated with something significant is fairly low. But I will tell you that there has been a statistical association with type 2 diabetes. Okay, you probably already know, but let's just say somebody comes in and they got a bunch of skin tags. Ask them if their family history is full of skin tags. If they say, no, my mom and dad didn't have them, but I've got them all over the place, ask them about the usual symptomatic review systems to look for things that suggest diabetes, polyuria, polydipsia, polyphagia, et cetera, et cetera. It's not a big deal. They tend to be associated. There was a time when we thought they were associated with colonic polyps that were pre-malignant. I think that's been, I have a yes and a no here, but since then there have been more no's than almost no yeses. So that's probably not true. But the last one is pretty interesting. Perianal, that's not a usual place to get skin tags. It's the neck, axilla, and groin. if they have them all around the perianal area, ask about GI symptoms that might suggest inflammatory bowel disease. Cramping, blood, pus, loose stools. You know what to ask. So, because this can be the first reason they seek medical attention, or maybe it's an add-on reason. You've done everything else, and now they say, "Oh, I got these little bumps back here. Can you help me with them?" And it is absolutely astounding to me, because there are other skin signs of internal diseases, including inflammatory bowel disease. It is absolutely astounding to me how patients will rationalize things away. Isn't it? You all have probably seen this. They come in and you make the diagnosis ultimately of diabetes or inflammatory bowel disease. And they've had these symptoms for 4 months, 6 months, a year, 2 years. Well, I thought it was the Mexican food I ate 3 years ago. It's still giving me diarrhea and blood. What? Isn't it true? I mean, you see patients like that all the time. So perianal skin tags should prompt you to ask for the symptoms that might suggest inflammatory bowel disease. And I can tell you at least a dozen patients, I'm the dermatologist. I make the diagnosis of probable inflammatory bowel disease, who went on to go see then their gastroenterologist and had appropriate endoscopy and appropriate exam and were diagnosed. And they had the symptoms, they just didn't want to admit that they had the symptoms. But I forced them because they had skin tags around their perianal region. So keep that one in mind. Hard pigmented nodule on the leg. This is prototypical. This is what it looks like. It's very, very common. These are called dermatofibromas. We don't know why they appear. They tend to be symmetric frequently. They only primarily affect the arms and legs, more the legs than the arms. The theory is, and there are people who've done sophisticated, weird stains looking for different things. The theory is that this is an abnormal reaction to insect bites. Not bites they had yesterday, but bites they had a long time ago. They dismissed because they went away, and then all of a sudden they have this lumpy thing there. And they will often tell you, I had a bunch of bites right there when I was out in a safari somewhere or something. So they might be reactions to bite. We don't really know. They look ominous because they're pigmented. But the thing they do, I'm going to show you an example, the thing they do that nothing bad does, if you pinch them, you put your thumb and your first finger on each side and you squeeze, they actually dimple. You think about something that's elevated, if you squeeze it, you think, oh, it's going to be hard and it's going to stay exactly like it is. But for reasons that no one's actually been able to explain, they actually invaginate, they go in. And that's a very, very typical sign for dermatofibroma. It's called Fitzpatrick's sign. And how are these taken out? They really have to be excised. You can't shave them because most of the lesion is actually deep under the skin. So if you try and shave it, you're going to leave most of the lesion in there. So here's some more pigmented, hard legs. And see that? You can see actually my fingers on each side of that one, and it dells in. There's another one, dells in. Then you let go and it pops back up. So that's dermatofibroma. Common extremities. They generally don't itch, burn, sting, or hurt, so they're asymptomatic, but they bother people because they're hard. Women who shave their legs may shave over them and constantly get them irritated and bleeding and even secondarily infected, so that's a good reason to take them off. Okay, vascular lesions. Again, very, very, very common. So another name for this is Campbell-De Morgan spots, because Campbell and De Morgan were two physicians, barbers, those kind of whatever they were, back in the 1700s, who described this originally. They're benign familial vascular proliferations. They're very common. Most of the time, there are lots of them. Because it's seen in older individuals, for a long time it was called a senile angioma. Well, I'm not senile and I have them, so I don't like using that. So then another name is cherry angiomas because they look like cherry color, right? I think that's the gentlest thing to call them. if the patients want, what is this thing? And almost everybody over 60 has at least one. Some people have lots of them. They tend to be on the torso primarily, but also on the extremities. If they get really big and they're sitting in the wrong place, like right under a belt line, then they can get irritated and bleed. They're of no medical importance whatsoever, and they can be destroyed by cooking them. If there are lots of them or they're big, certain lasers like pulse dye laser will work, but just cooking them is usually sufficient. And here are people with lots of them, fairly dramatic ones. Now they do vary in color, so they can be everything from cherry color, like the color of the exit sign, or they can be very dark and actually resemble melanoma. So you walk in the room, you see this thing, here are sort of cherry colored ones, and the other ones are darker, especially that one. So she was all bent out of shape, thought she had a melanoma, yada yada, and they're absolutely nothing. Here's a really dark one though. So they can be of some concern, and you may biopsy or remove them because you're not sure. Remember what I said, not sure, biopsy or remove it. Venous lake is another vascular malformation that's acquired later in life. They're everything from red to black. They're usually on the lips and the ears. And the thing that distinguishes these, you can't do this with the cherry angiomas, but the venous lake is a very thin-walled. It's venous in its origin. It's very thin-walled, and you can compress it, and it totally disappears. Then you let go, and it comes back. And these are often quite dark and really suggest melanoma. And of course, on the ears in particular, that's a spot where melanoma not uncommonly occurs. So look at these. I've given you a whole bunch of them, everything from red to near black. But here's what you can do. If you walked in and you saw a lesion that color on the ear of an older individual, your synapses should be firing melanoma. You just walk in and look. But it's on the ears. Uncatetti told me these can be venous lakes. So I'm going to put a little pressure on it. And where'd it go? Sort of disappeared because they're totally compressible. They're thin-walled, filled with blood. You compress them, the blood's gone. There's nothing to see. You can't do that with a melanoma. So remember, that's a nice way to distinguish between these two. And you can burn them off if they need to be burned, or they can be treated, if they're bigger, with laser. Nd:YAG's probably the best laser to use for this. This is one treatment, and it's gone. Almost painless, easy to do. If you don't have these or don't have access, you don't do laser stuff, almost every dermatologist in the world has an Nd:YAG laser. They can kill these things. Okay, pyogenic granuloma is another acquired benign vascular lesion, but these can be seen in young people as well as older individuals, and they're sometimes associated with pregnancy. What distinguishes them is they're very friable. If you look at them the wrong way, they'll bleed. If they're touched, if they're traumatized, they bleed. And sometimes they bleed very profusely. And they often have a moist, glistening appearance to their surface. I'll show you pictures. Once you see it, you know it. They can be dark, so they can suggest melanoma. They can suggest other tumors. Most people want these off because they bleed. They have a geographic preference. They really like the fingers and they like the lip. But they look much different than a venous lake, for example, which is what I just showed you. So there's do you see how much angrier they look? Redder, and if you touch them, they bleed. Touch it, it bleeds and has that sort of glistening surface to it. Finger, lip, face, touch it, it bleeds. There's a really big one. That's the biggest one I think I've ever seen. So a couple more. Okay, one thing about removing pyogenic granulomas. Most of the lesion is above the skin, so you see the visible thing. But there's usually some big feeder vessels that are down deep. So if you just cut these off, flush with the skin, and do a little pressure, a little dry sol to stop the bleeding, they'll come back. They have a high propensity to come back. Almost everything we've talked about up until now doesn't. Once it's gone, it's gone. but these like to come back. So sometimes they really need to be excised, not just shaved or snipped off. If you do shave or snip off, you really don't use some minimal method of hemostasis. You really need to use electrodesiccation, electrocautery, and you need to try and seal off that feeder vessel so it doesn't just lead to a brand new one in the exact same place. So you fry it until it really looks like a piece of overdone barbecue. Okay, around the eyes, remember what I said about Trico Epithelioma, benign, flesh-colored, center face. These are benign, flesh-colored, smaller, but only around the eyes. Very, very typical geography. And these are called syringomas. They're actually a derivative of the sweat gland. They're a portion of the sweat gland anatomically that proliferates. There may be one, there may be lots of them. There's a differential diagnosis. Once you know, I usually like to take one off just to make sure, just one, snip it, shave it, just take one just to make sure. And then you can electrodesiccate away to your heart's content. They do have a tendency to come back, so you have to balance the risk and benefit there, but very, very common around the eyes, syringomas, flesh-colored, usually multiple. Leiomyoma is a rare tumor, but it has a very distinctive feature. It hurts. Almost none of these hurt. I haven't said the word pain or hurt the whole time I've been lecturing. These hurt. They hurt spontaneously, and they really hurt if somebody goes out in the cold. Sometimes they'll hurt. I've had people say when I open a refrigerator, they stand there for a while and the cold gets on them. They tend to like the arms and the shoulders in particular. Some may occur on the genitalia, but they're usually just as one. And most people don't put their genitalia in the refrigerator. So you don't have to worry too much about that. You can punch them out if there's just one. If there are multiple of them, it becomes a major cosmetic problem. They're difficult. Now, this one is a well-known association. Some of those other associations I told you about, not so important, not common. But this one is. So leiomyomas in women, there's an autosomal dominant disease. It's called Reed's syndrome. So they have leiomyomas of the skin. They have uterine leiomyomas, so they may be having cramps, especially with periods. They may have abdominal pain. They may have intermenstrual bleeding. If they're postmenopausal, they may have spotting, so bleeding and pain. But the other part of this syndrome is renal cell carcinoma. So anytime, and I haven't said this about any of these other syndromal things, anytime you see this, I'll show you pictures in a second, you see leiomyomas in a woman, they probably need CAT scan, they need to have their kidneys radiographically examined. So what do these things look like? That's what they look like. This woman came in because she was finally tired of having these. She had intramenstrual bleeding, and she had asymptomatic renal cell carcinoma. And it's a dominant, so the person needs to know because there's a 50-50 chance they'll pass them on to their offspring. So it's a very, very important. This is a real and important connection. These reddish-brown, firm papules and nodules, particularly on the arms, sometimes the neck, that hurt. They hurt spontaneously. They hurt if you push on them. They hurt if they go in cold weather. In a woman, think renal cell carcinoma as a possibility. And even if an evaluation is negative on day one, they need to know that that's a risk. And they may need to be periodically re-examined and certainly warned about asymptomatic hematuria and stuff like that that might be a symptom of renal cell carcinoma. Here's some more. It's that same sort of flat papule nodule. This is on the neck. And then fat. These are lipomas, big fatty tumors. They are freely movable. Remember that lipomas or something like a lipoma can certainly occur in children too. They're not mature fat cells. They're immature fat cells. So they have a different name, but they're basically a lipoma. It's a benign fatty tumor. And here are some of the other ones like hibernoma, lipoblastoma. These occur more in children, younger adults rather than older adults. When fat tumor is infiltrated with blood cells, it also hurts. Glomus tumor hurts. Angiolipoma hurts. Leiomyoma hurts. Glomus tumor occurs under the nails. Those are three of the big painful tumors. There's a big fatty tumor. You wouldn't know that for sure until it was biopsied or excised. There's no way to, you don't, unless you have X-ray vision, X-ray histology vision. But it can occur in children. I just wanted to point that out. Lipomas are easy to remove. Straight line excision right over them. Put pressure, out they pop. Bingo, lipoma out. They're usually encapsulated, so they come out as, not like the cheesy material from a cyst, they come out as an intact clump of fat. These are deep though. They're in the fat, so you leave a hole when you remove them, and you don't want serum to collect there because that is a great culture medium. So make sure these should be closed with deep sutures as well as superficial sutures. And then last, pigmented tumors. These are the liver spots, the bane of everyone's existence. They're common. The problem is this, size. When they start getting bigger, remember, these are flat, there's nothing to feel, they're pigmented. It can be a lentigo maligna melanoma or a lentigo maligna. Those are flat pigmented things that are actually dangerous. So how do you tell? Is this benign, or is this just a big benign flat pigmented thing in an older person, or is this melanoma? If you find an area that looks different than the rest, you probably need to biopsy it. If you see this, where there are variations in color, there's nothing much to feel, but there are variations in color, or there are white areas, which is regression. That's the body's own immune system killing the bad pigmented cells. Think about cancer. So again, variation in color. Not much to feel, variation in color, irregular outline, areas where the thing has been regressing on its own. This is a common phenomenon, and if you're not familiar with it, it might scare you when you see it. It's like someone, there are at least some of us in the room who remember fountain pens. It's like a drop of ink hits the skin and sort of spreads out a little bit. It's called the ink spot lentigo. You see it on the chest, the back, and the shoulders. It looks like this. It's sort of little lines of pigments, totally benign. It's never a problem. There's another one, has that very, very uniform appearance, ink spot lentigo. These are no longer bleached out. They're no longer frozen off. Lasers totally destroy them. There's a whole bunch of lasers that gets rid of them, and you don't have to think about them. The last thing I want to mention in the way of pigment, they're moles, and there are lots of moles. I mean, there's all kinds of moles, and they come in different sizes and different colors and different textures. But here's what I think is the important thing. When do you need to worry about a mole? If it's changing. If it has irregular borders, multiple colors. But the big thing about a mole is it's changing, or it becomes symptomatic. All of a sudden it starts hurting, or it starts bleeding. Moles can transform into melanoma. Sometimes it's melanoma that everyone thought was just a mole, but any symptoms should make you worry about. And the other thing is the so-called ugly duck sign. You walk in the room, they have a whole bunch of moles, but there's one that looks different from the rest. That's the one you need to worry about. So that's when you worry. Taking off moles, you adapt to the size and shape, just like a lot of other things. You can snip it, you can shave it, punch it, excise it. If you take off any pigmented lesion, it must go in a bottle and be sent off to the pathologist. If you see a bunch of big ones, ask about a family history of melanoma. A bunch of big ones, because there's a familial dysplastic mole syndrome, which is not uncommon. Anybody else in the family have melanoma? Yes, then you need to worry about these. Some of them may need to be biopsy removed. They certainly need repeated examinations. It's best done with photography so you see anything that changes. Big moles. Look at those. Those all should make you have a little bit of discomfort because of the irregularity in color, Sometimes the shape isn't exactly nice on the outside. Those are all dysplastic that not malignant. They're heading in the wrong direction. They may never turn into melanoma, but they might. So all of these kind of moles, but they look a little funny, especially with a family history of melanoma, they should all be removed, or at least biopsied. If somebody has, I'll tell you my very brief story, I'm almost done. A fellow came in, I walked in, first new patient. He said, "Do you know who I am?" Well, I did, because I looked at the chart. He's the most notorious plaintiff's attorney in Houston. My father died of melanoma, my brother died of melanoma, and I don't want to die of melanoma. Here, he took his undershirt off, and he had 350 nevi. And they were all big, and they all looked crappy. So I said, "Excuse me 1 second, I'll be right back." I went out and I really quickly typed an informed consent that said, "I can't guarantee you won't die of melanoma." And then I biopsied about 12 of the worst ones. One was a melanoma. The other ones were severely dysplastic nevi, so I took those off. Over the years, we've actually become sort of friends, and he's still alive, but then he sent all his partners, all malpractice attorneys. Oh my God, it's just totally disgusting. So when in doubt, biopsy. When you're not in doubt, biopsy, send it off. Pigmented lesions, send it off all the time, no doubt about it. And then if people are born with them, if they're the size of the palm of the individual at that age or bigger, they have a high propensity to develop melanoma in them. All of those large lesions, at some point they need off, because at some point they may develop melanoma. So they're benign as they're sitting there, but the future is uncertain. So I hope I've gone through a lot of stuff in a short period of time. I hope I've helped you and given you some clinical pearls on how to deal with these things, most of which are banal and not threatening, but some of which, especially towards the end of the lecture, are.